Welcome back to part 2 of episode 2, entitled Power and Privilege Dynamics in the Clinical Encounter. We rejoin our speakers, Dr. Shrikant Peters, Prof. Lydia Cairncross, and Vera Hlayisi, in a discussion around how racial discrimination manifests in the clinical setting. And in this part, we will examine who this discrimination predominantly affects and the subconscious biases that feed into these structures of violence.
So we are now moving on to a set of questions that we would like to open to the floor. We want to have some discussion and we want to hear you guys talk to each other, reply to each other, and bounce ideas off each other, because that's the best way to really interact with a new concept. So first off, what are the factors that put medical professionals at risk of being discriminated against within the clinical practice?
If I can go first, Asande, I will call you guys out. The way that your question is worded, it makes it the problem of the person who's being discriminated against. So what puts me at risk of being discriminated against? It changes the narrative to become, how can I not be at risk of being discriminated? And I think, first of all, that's the other way around. How can we lessen discrimination, period? And I think, just the basic of informing people, number one, for example, of issues that Prof mentioned earlier. Unconscious bias is really, really a big thing, and we all struggle from it, not on just issues of race, but also on issues of sex, on issues of age, language. There's just so many things that are intersecting. I just thought, because you said debate and engagement, I'll call you out. You can't put yourself at risk of being discriminated on. It is the discriminator's problem that they're discriminating, not that you're doing something to say, hey, come over here and discriminate against me.
I love that. Thank you for calling us out. Actually, really got me excited for the conversation. Anyone else want to jump in on that?
I'll come in there a little bit, Kelsey. I think one of the for me, one of the disappointments of our new democracy is that we haven't surfaced and dealt with centuries of indoctrination around class, race, and privilege. And it's interesting that we have to surface a problem which it's obviously going to be there. Why would we somehow have unlearned all of that in a short period of time, particularly when the way that we live our lives reinforces that prejudice all the time? So for me, as a surgeon, working in a male-dominated, mostly white male-dominated environment, as a Black woman who looks younger, I feel that prejudice every single day. So I don't look like a surgeon is supposed to look for most patients and for most staff. Over time, you forget it, because in your context where you are familiar and people get to know you, you manage to make space for yourself. And I think that's one of the things that Black South Africans really experience, is having to make space for yourself wherever you are, and women in particular. So over time you make space for yourself, and then you're recognized, and people know, obviously, okay, so now you fit into the hierarchy, and therefore you get the respect that goes with that position. But as soon as you move out of your regular space, like for example becoming a COVID doctor, it just reminds you again that how people see you when they see you is they put you into a particular box within the health system. So you're either going to be the nurse or maybe the sister, and it's an everyday, every ward, every place I go to phenomenon throughout my entire career. And even though most doctors now are women, in the minds of many of our patients, and a lot of this sexism and racism is coming from patients, and a lot of it from Black patients. So patients have a particular idea. So, I mean, we've all experienced this as doctors and as women. If you're on the ward round and you happen to be with a tall white intern or student, the patients always look for the decision making to the person that they think is the decision maker. And everyone gets really uncomfortable, and we kind of like brush it over and we kind of move on. And we haven't developed ways for us as a community of health workers, because, you know, in health we have healthcare workers, doctors, nurses, and OTs, physios, audiologists, and we also have health workers, those other workers that keep the hospital going, porters, cleaners, kitchen workers. Those are all health workers as well. They're just not specifically healthcare workers. As a health worker community, we haven't found ways to actually address those things and begin to break them down. So we just live with them and we pretend that they don't exist, and we put them under the surface. And they do affect patient care, because sometimes patients will take a while to develop a rapport and trust with somebody they think doesn't look like the kind of professional that that should be doing what needs to be done. It's easy to become very bitter and cynical over time, which I think is important not to be, because we have to find a way to build a new kind of society. We have to break through this as a collective. And the first step in that is the recognition that it exists. That when certain people walk into a room, power just gravitates to them. If you look a certain way and you're a particular age, you're a particular gender, and you're defined by in a particular race, the power flows to you, and it's a habit of rule. People look to you for the decision, and it's just as easy as breathing. And for other people, when they walk into the room, they have to be on point, brilliant, make their space, be amazing, and then there's space for them. So if we can begin to understand and to surface and have an understanding of our positionality at all levels, then I think we can work our way out of this nightmare, really, where we are all dehumanized by being boxed into categories as we are at the moment.
I'm seeing that Vera has something to add to what Prof. Cairncross has just said, and we're so excited to hear what you say.
Yeah, I think I really just wanted to agree on Prof's explanation and description of power dynamics. I think also in our generation, you know, I will very cautiously say our, because, you know, Prof has done so much more. But in our generation of young woke, if I can still say that, if that's still a word that this generation uses, young woke professionals that are, you know, having discourse like this and trying to break these barriers down, a lot of us are also guilty of just climbing up the existing hierarchy of power dynamics and then taking up our own little space so we can exist. And I think what actually needs to happen is we need to reconfigure the hierarchy model, because it still doesn't change the hierarchy. It just means, you know, we've made space for one Prof and one Dr. Peters and a one Vera, but then the rest of the hierarchy still exists, and we're all reinforcing it, you know, by sometimes you just shrug it away, you know, on the day when you're not in the mood to reinforce that, you know, actually I'm the person who makes the decision, and so on and so forth. And I really just wanted to say that in many ways, we are all part of reinforcing the entire system. The fact that you always have to be excellent to claim the space. You know, if there was an environment where you didn't have to claim the space in the first place, then when an Asande comes in later on, then that wouldn't be, you know, a reality for her. So I really just wanted to speak to that regarding power dynamics.
That was so insightful, Vera. Dr. Peters, just taking it back to you again, do you have any comments with regard to what you think is valuable when it comes to this conversation?
Yeah, so I mean, my thoughts have gone from idea to idea, but what we were discussing earlier about, you know, and when you were called out on your question, something that struck me about disability, right? So there's different levels. I think the question, I'll just walk you through my ideas. You asked, what are the factors that put medical professionals at risk of discrimination? And, you know, when I heard that, it's literally any which way you can categorize and group people can be a risk factor for discrimination. And like we were saying, race, age, language, disability. But when you get to something like disability, where the light really switched on for me was a simple reading where I was told the word disabled is not a noun, it's a verb. Right? You're not a disabled person. Disabling is something that's done to you, right? And that's literally, it's about the system and what people are doing and where you've been placed, not necessarily what is your inherent worth or value or quality of life. And what I really feel is there's this concept called social capital, right? And it's networks and relationships, and it creates this free flow of resources between people who have social capital with each other. And the categories that we have, those can be race, gender, age, language. Social capital flows freely within those categories. And so you'll see this phenomenon of ward rounds where people of the same language will interact with each other far more freely. People of the same race will understand the kinds of places where they live and the kinds of resources they have access to. I mean, I was taken back to being a fourth year on the rounds at Red Cross. And obviously most of the kids there, you know, come from impoverished backgrounds. Most of them are non-white. And every once in a while you'd get a family member who, and you know, they're there, a white patient with a white mom. And for some reason we'd spend sort of half an hour on the ward round, whereas everyone else we've given 10 minutes to. And there was a lot assumed in the interactions that, you know, you could possibly go home earlier because it's most likely that you've got good access to hygiene and sanitation, and we can trust you to look after your child. And those are all unspoken, but you could clearly see it as a student on that round, the way the clinicians interacted with different races of people. And I find it interesting to think of in that way, of bubbles of social capital that aggregate with themselves. And as you become interns, comserves, registrars, you'll notice that those bubbles of social capital, they extend from being more conversant in the ward rounds to, you know, being accepted to a BRI, maybe with the consultant over the weekends, and maybe at that BRI you'll get some training for your Part 2 exams. And it's all not done specifically to disadvantage people, but it's innocuous in how you then end up concentrating the value of the interactions within certain groups of people, and other people lose out.
That was very insightful. What I liked at the end there was those bubbles of social capital and how you end up like segregating those interactions. And it's not really something we do intentionally, but it happens. And I want to kind of go back to something Prof. Cairncross mentioned. She was talking about how sometimes your patients might not trust you because you don't look like what they envision a doctor to be. And the question I wanted to pose to Prof. Cairncross was, have you ever had a moment where you felt guilty because you couldn't go through to a patient? And for any other healthcare practitioner listening to this who's going through that, that's something that we're supposed to feel guilty about, be bitter about, because often it's our task to reach out and help them. So what happens if there's a barrier there that isn't necessarily of our making, if I'm leading the question in the right direction?
Yeah, thank you. It's very difficult. I think, you know, people who are trying to change the way things are carry a heavier burden, and I think the complexity for me comes in, there is the power dynamic of the surgeon and the person who needs the operation, which is a huge power gradient. Now we layer on race and gender and age, and the perceptions of the patients of where you position in that. So now, do you reinforce the power gradient of yourself as the surgeon and you are the patient, in order to consolidate a trusting relationship? In other words, you to refer to what Vera was speaking about earlier, that you use the system hierarchy to give yourself power, essentially, and to reestablish that relationship where I'm the doctor, I know, and you're the patient, and sign the form for consent. Or do we try and find another way of doing these interactions? So for me, I think, no, I don't feel guilt about it. I sometimes feel tired about it, but I find that with time, I have not had a patient who has not come around. So with time and repeated interactions, and just talking, and showing empathy, you can build that trust and that bridge with a farmer from Kimberley, you know, who's Afrikaans speaking and might have a very different political perspective, and it is possible to do that. And I think this is the challenge for us, is to find a way to acknowledge and to fight against these prejudices and the racism and the sexism that we experience, and through that to find a way to a new kind of humanity through all of that. So people are very disparaging of sort of the those that say that race doesn't matter and non-racialism and so on, because it negates this experience, which is a real experience, which is the experience of racism and sexism. And for us to get to this new reality, the first thing we have to do is to surface and acknowledge that it exists. And when in the clinical environment, I find that the best way to do that is to find a way to relate to the other person as a person, so they can find a way to relate to you as a person, which is not always easy. I've seen some of the most painful experiences of racism have actually not been personally with me, but some of my colleagues, watching how they have been treated, not only by patients, but other clinicians within the hospital, in the kind of interdepartmental friction and conflict that sometimes happens, often overtones of racism and sexism. And it can become tiring to always have to rise above that and find a new way to be and to work. And that's why I think that it cannot be an individual thing. There has to be a systematic approach to surfacing and dealing with racism, sexism, ageism, and all the discrimination that we see. It's around sexual orientation as well. There has to be some kind of movement that we build, where all of us have the humility to accept that we have unconscious bias. All of us, we all have it. That we have all been indoctrinated not to see someone who does not look like us as somebody who could be us. So this definition of the other. And that, because it's been structurally and systematically implemented, we have to structurally and systematically dismantle it. It's not just about what I do with one patient. I need to change that whole environment, which is the big work that needs to happen.
I just wanted to jump in with something that was really like illuminating to me, was listening to sort of the combination of Prof, what you said, and also then Vera, what you said. As for me, it's like a conversation here is incredibly important, because I don't feel like I've ever been exposed to this idea as a med school student. Just the idea of, we reinforce that hierarchy, we climb that hierarchy, we work really hard to get that respect in the hierarchy, and we think that when we get to that level, the respect is going to come with it. But then when you experience that that sort of unconscious bias of a patient, to reinforce it or not to reinforce it, how do you, for me, it was just so like new. I don't know, it's not a new idea, but to me it was so new for you, Prof, to say like, do you or do you not reinforce it? Do you get angry about it or do you not get angry about it? How do we don't learn this in medical school, you know? So I think it's really important to teach, or to just speak about it. And I really like the idea of the future is not to have to learn to deal with it or back down. The future is to break down that hierarchy, break down the idea that you need to make space for yourself. You should just, you know, be welcome in it. Sorry, Dr. Peters, you had something to say.
Thanks. Sorry, just on that question of, you know, do you get angry about it? I'm not really a conflict. I don't really run towards conflict, but sometimes you do have to get angry about it. I remember one of the nights on call, I was an intern in Durban, in the north, in an area which is pretty much predominantly Indian. And as an intern in pediatrics, you can have some very scary calls. And as someone who was thinking of doing pediatrics once upon a time, you know, it can be very, very daunting. I remember finishing clerking a patient. It's an Indian family, and obviously everyone's very scared. You know, you're taking your kid in. You want to afford private healthcare, but you can't always. and you've got a doctor here with you, okay, seems to be a bit young, but has a treatment plan for your little 6-month-old, and you just want the drugs and you want to go home. And so I said to them, yes, I'm the intern, and don't worry, the registrar will see you now. I could have been a bit more specific. Not everyone knows what a registrar is. And lo and behold, down the corridor, there's my registrar coming to assess what I've done. And it's a black registrar. And the family members, the mother and father, look at each other very worried. And they say to me quickly, like, doctor, please, don't you just want to write something and let him go? We don't want that doctor to see our baby. And you have to interrogate exactly what they're saying and why they feel that way. Otherwise, it reinforces the stereotypes and assumptions, and it actually makes you look like you understand what they're saying, and it makes it look as if they're being rational. So you have to tell them, look, I mean, I am as good as a layman out of medical school. This is the specialist in training who is going to see your baby and give absolute value and quality care. So sometimes you do have to confront it, and sometimes, you know, when you move in these circles, which you're very privileged to be academically inclined and tertiary qualified, and at these upper levels, some of these other categories tend to fall away, like race and language. And for people that have access to money, it's far easier to have access to people of other races. And for other people, it's not really that possible. And it's important to tell people, to describe to people that, yes, it's possible to be competent and not be white. Because the assumptions that you get to by the end of 6th year are very subjective clinical assessment methods and this toxic ego environment of clinical medicine. The problem is, what I realized in 6th year is an issue of competence and confidence, right? So you're assumed to be competent if you're of a certain race, and if you're not of a certain race. And sort of what Biko would say is there's this learned helplessness. If you get told that you're not competent and you feel that you're not competent, over time you start lacking confidence in yourself. And then it becomes this self-fulfilling cycle that goes on. So competence and confidence, that's what I remember.
That was very powerful, just listening to how you touched on those different anecdotes, came in with that competence, confidence, and how it can be influenced by external factors. So we've just talked about those various factors and how they can lend themselves to discriminatory practices. We've talked about the experiences that you guys have had as medical professionals, and we just want to kind of wrap up this conversation with looking at what any of you have done to advocate for change in your spaces. I know Dr. Peters has just touched on some of his experiences, but maybe if Prof. Cairncross and Vera want to come in with any advocacy they've done to change the systems they felt are in place that disadvantage those stakeholders that take part in them.
Sure, Asande. Thank you for the question. So I'll speak to something that is fairly recent. I, as an audiologist, a lot of our work that we do with speech therapy has to do with language. You know, because your sense of hearing enables you to learn a language that is verbal if you have the hearing ability, and so you end up in a hearing and a speaking community. And you know, that's the basic science of, you know, of how it works and how the brain interprets sounds into a language. The backhanded side of it is, in our profession, there've actually been a lot of using language as a proxy for employment. So you, Asande, or Dr. Peters, you could be a qualified best speech therapist in the world, best audiologist in the world, but in employment adverts, there'd actually be a language that you're required to speak and be proficient in. And for me, you know, as a young professional, I never used to see it as a racial proxy, because then at the end of the day, depending on, you know, where the employment opportunities are, and if we look at socioeconomic structures, it's Western Cape, it's Gauteng, and it's Durban. And if you actually wanting to move up a, you know, a particular level in employment and prosperity, you end up realizing that, oh, okay, so if you're proficient in English and Afrikaans and it's your home language, then you get certain job opportunities, because it is assumed then that you're a good speech therapist because you are Afrikaans speaking. But then I think, you know, in our professional association, we went back and we dismantled it, because when you come into the education system as a speech therapist, everyone gets taught, you know, the basics of language, the linguistics. You get taught how to build language. Whether you can speak isiXhosa, isiSotho, isiZulu, sign language, the brain learns in a particular way, and therefore you are able to provide therapy for a child of any language. Be that as it may, it doesn't make it easy, but it doesn't make it something that can be an employment requirement. And I think as an association, we've worked very hard on creating a language policy that says you can't exclude someone from employment based on, you know, a language proxy. You can't say, oh, Lydia, you can't speak isiXhosa, oh, we can't employ you in the Eastern Cape. Because then over time, what that has created is that a speech therapist has always looked a certain way in a certain area, because then they say, oh, but we want them to speak in, you know, in a particular language. And that has not necessarily been scientifically related to your competence, if I link to Dr. Peters earlier. And so that has been one of the, you know, the progressive things that we've actually only managed to do in 2020. And we're trying to work it to a point where, you know, as an employer, in private or in public, you can't put in a job advert, we want an English speaking speech therapist. You just want a speech therapist. No one ever says we want a English speaking surgeon. you just want the person with the skills. What language they speak, that's separate, because then, for example, as a public facility, you're supposed to have translators for any other language in the facility. So that was one of the things that I'm very proud to say, that we sort of having a movement forward in speech therapy and audiology.
That's fantastic. Thank you so much. Prof, did you want to say something?
Just to come in. So what have we done? So I think Shri, I agree with you. Sometimes you just got to call it out, and I think particularly I've felt that, and so this would be the first part of it, is three things: challenge, surface, and change. So I think where we see these prejudices around us, we need to challenge them, and that is actually quite powerful, even at an issue by issue. Something gets posted on a WhatsApp group which is racist or sexist or anti-poor. We need to challenge it. When someone says something on a ward round or in the change room or just around us, you know, we don't want to be awkward or to be that endlessly that person that has issues. But I think the more that we challenge racism and sexism as it comes up, the more we will create an environment where we don't tolerate it. So that would be my first thing, and it is something that I try to do every day in my work. I'm sure there are days where I fail at it and I don't manage. And I also try to defend my team members at work where I think patients are ill-treating them or other colleagues, because that also happens. So I think challenge, it's never small. It might look like a small thing, it's never small. That's why it's a microaggression and it's structural violence. That feeling that you get in your stomach when something is happening that feels bad, that's real. So say it. So I think that's my number one. We just need to say it more, because people are too comfortable with floating along in the sea of kind of prejudice that we have. And then secondly, surface the issue in a clear way. So we have a transformation committee in surgery, and just the creation of the transformation committee in surgery has surfaced a lot of the issues. The fact that we need to have a transformation committee highlights the issues. We've done an institutional climate survey within our department, looking at experiences of racism and sexism. And the majority of registrars and consultants have experienced racism and sexism during their working life. And presenting that kind of data to our divisional heads and to our research day, I think really started a conversation on what is happening with these unseen but very powerful things that are going on within the department. So that's about surfacing it. And then the third part on change is a work in progress. So we are planning to do diversity training and sensitization training with the leadership of the Department of Surgery. It has not been done as yet, but that is something that the Transformation Committee is going to push very hard for, because we need a re-education, particularly of our leadership. And the re-education has to start with very basic things like, what is a sexist comment? Why is it not okay to call the women working with you girls or chicks? What constitutes a racist comment or a xenophobic comment? This is a learning that needs to be done. It's a profound incompetence that we have in many of our leading clinicians in the hospital, I have to say. So re-education, even in a formal process like this kind of training is where we need to start. And then I think broader re-education of all of us. So in some professional colleges examining students throughout the world in surgery and others, they have specific courses on assessing and understanding unconscious bias when examining candidates. And I think health professionals should have training in unearthing and examining unconscious bias in the way that they treat patients. And I love your idea that we need to do some of this conversation and teaching as part of undergraduate teaching. And I hadn't thought of that, but that's a great idea. And I think we should take it forward. So those would be my sort of 3 pillars, some of it done and some of it still aspirational.
We just so sorry.
Sorry, that valuable input that you gave us. What I really appreciated was how you mentioned that people are too comfortable floating in a sea of prejudice. I think that really hit home for me in terms of what I've seen play out in small things like TUT groups as well. But we're moving on to a section where we need to acknowledge that sometimes these practices of discrimination can be a lot more insidious. And again, we're opening it up to the panel. So we're opening up to that open conversation, trying to examine how research can kind of instill those discriminatory thoughts in us. And this is very important because research is supposed to be the cornerstone of evidence-based medicine, but we still need to critically analyze how that research has been done and how it still gives us some faulty ideas every now and then. So can we start possibly with Dr. Peters?
Hi. Thanks. Yeah, so this question came up in planning for our podcast, and we had gotten to talking about whether racism exists in research. I think everyone understands the table 1s in your research papers that demonstrate sort of Black, white, Indian, Asian, and then all the risk factors as they are laid out in the different races. And something that always comes up in public health circles is whether or not we should continue to have those kinds of tables in our research. Is it of value? Is it something we should look to, keep alive in the research, as it were? And what generally tends to come out is prevalence studies, incidence rates, what they call these intermediate risk factors, always settle differently in different population groups. Access to water and hygiene, sanitation, the kinds of plots of land that you have available to you, the rates of diabetes, crime rates in the different areas. And so even though we know that we're looking at race, or what our understanding of race is, we know that what we're really using race for is a proxy for disadvantage and socioeconomic status. There are obviously other measures for socioeconomic status that we can use, as like living standards measures. But if you were to see that nice photography expose of, I think it could have been Joburg, but might as well be Cape Town, where you can see the housing density on different sides of the road, or the fact that I can get from Century City in Cape Town back home to Pinelands without even having seen Kensington, even though it's right in the middle of those two things. You realize how structurally defined these things are. So yes, we keep race in research in the results that we generate, because there are still differences in the races, both in terms of risk factors and outcomes and the quadruple burden of disease. But also globally, in terms of research, there has to be this balance in terms of who bears the risk of research, so who gets experimented on, as it were, and to whom do the benefits of research accrue. And there needs to be a balance. If a population bears the risk, they also need to reap the benefit. And where there are major problems are studies which are done in Africa, but are then sort of marketed in America and then marketed back to third world countries with huge markups on the products that are generated from that research. So it's not as simple as it would seem, but there are definite ethical principles that underlie what should be the case when we talk about race in research.
Thank you so much for that, Dr. Peters. We saw, Vera, would you like to come in and comment on that?
Yes, I think, so many bells and alarms went off in my mind as soon as Dr. Peters mentioned the risk versus benefit ratio of research, who bears the risk versus who benefits. And the one key example, I think, if you have done any basic course in research, I'm sure, this example has come up in discussion on research on contraceptives. And obviously, that one is not necessarily rooted in our topic for today, which is racism, but it's just the sexism of how, how research has been done for females, contraceptive versus male contraceptive, what is accepted as a, okay, risk to approve for females versus, male contraceptive, and so on and so forth. And for me, I think one of the things that have been illuminated for me as a young researcher is it depends, in my experience, it has depended mainly on, what constitutes the ethical committee. Although I think in the black and white world, we would like to think, ethical principles are standard. I think who and what constitute the ethical committee of what institute or of what region makes a very, very big difference. Because, if I go back to the example of female contraceptives, a lot of the Eurocentric researchers went to a lot of Asian communities way back when that didn't know the wiser, and when someone offers you, a carrot, for a much bigger risk, and you don't know that. So based on their ethics there, it was fine to do over there. And I think now in retrospect, we're like, no, actually it wasn't fine. And so I think there has to be a standard ethical review of research. We can't keep having disparities in saying, if you want to go to a public facility, if you go to the Free State versus if you go to the Western Cape and Grooteskier, there's different rigor in the ethics committee and the ethics procedures that you have to go through in research. And the reason I'm hammering on the ethics is because if it's rigorous, it will have to go through the autonomy, the beneficence, and the consent, and the risk-benefit analysis. Say, is this community not over-researched or not? That is what hopefully we want ethics reviews to achieve. But unfortunately, in some instances, you have a manager of a hospital who's so inundated, they look at something. It comes from a university, it must be fine. They sign it off and they give an approval, versus other facilities that have rigorous procedures. So, because I think we can question the research once it's done and think about, was this useful? But I mean, I think if we have gatekeeping procedures that allow area A, area B, population A, population B to be equally safeguarded from any research where, you know, you have to be asked, why do you want to know someone's income? How is it adding any knowledge? You know, why do you want to know you know, their weight versus this, what, you know, of what scientific value is it, or of what knowledge value is. And I think the gatekeeping powers are the ones that we need to focus our energies on, that it's standardized so that no American or Eurocentric company can come to Africa and find, you know, for example, a COVID vaccine, and then, you know, in 3 years time we're buying it back from them. There has to be a standard, you know, risk benefit ratio from the ethics review processes.
That was really enlightening. Prof. Cairncross, do you have anything to add to that?
So Asande, I need a whole podcast for race in research. There's a lot to say about this. I think, yes, the power dynamics between the research and the researched and the beneficiary of the final product is one aspect. And as we know, power is racialized in the world as it is in our country. But the other big issue around race and research is the way medical scientists are reinforcing the myth of the biology of race in the way that they use racial categories unquestioningly. So if you look at a lot of research papers, there is often use of racial categories with no explanation of how those categories are defined, how they've been assigned to different people, who has done the assigning. Is it the front clerk at the hospital who wrote the address and the language, and we've then kind of done the racial classification, and then we are saying something related to their breast cancer risk is related to that category. So the scientific rigor that is applied to every other variable that is measured is not applied to the category of race. Secondly, there is a blurring of the lines between using race as a proxy for socioeconomic issues and socioeconomic disparities, and using race as biology. And it's a very, very dangerous blurring of the lines. We need to crisp up those lines, because the same people that deny the existence of racial prejudice as a powerful social, economic, and political force in society are the same people that will unquestioningly and unblinkingly use the biology of race in their research projects. And we need to separate those two things out. Race as biology does not exist. Racism and race as a socio-political construct and force in society does exist, and it impacts on people's lives. And as medical scientists, we need to get our facts clear, we need to get our ethics straight, and as a medical community, we need to take responsibility for how we intersect with this issue of the biology of race. It's dangerous, it's inaccurate, and it needs to change.
For me, what was really, really important about listening to all of the different factors that has been brought forward is the idea of understanding your unconscious bias and seeing research for what it is, and have they used race as a proxy, as been mentioned, for socioeconomic status, or has it been used as biology? Have they even analyzed, has it gone through the ethical process of analyzing why those specific factors are being included? And so that sort of leads into my next question, which is, because research informs our medical practice and has been discriminatory against groups in the past, how do we go about correcting these imbalances in our daily practice in the future? Any advice?
I'm conscious that we're running out of time, but I think every single time an article mentions race, ask for it to be unpacked. What do you mean race? Which races? The races like defined in America, the races as defined by Footwood, which ones? And who decided the race? Was it the patient? Was it you? Was it in a file somewhere? Just asking the question will surface the issue. And so we can start to be conscious of the way we use it in our research. That's the first step.
Thank you. Anyone else want to jump in on that?
Yeah, sure. I think on the issue of challenging and surfacing in order to lead to change, I'm stealing that one, Prof. Is ask yourself as a reader. I would like to believe all health professionals, you're a lifelong learner. You must always interrogate what, how would me knowing a person's race change the way I intervene? How does it change the intervention? Because it then interrogates the using race as biology and the biology of race. Because say, for example, you're talking about diabetes, you treat diabetes in a particular way. If you want to talk about lifestyle and external factors that exacerbate symptoms, that's a separate conversation. But how does this help me? What do I now know? After reading this article, what do I now know? What are you telling me? And if it's specific to race, what do I now know that I didn't know before? What are you highlighting, and what is the solution? So be an interrogative reader. Don't be a flaccid and passive receiver of knowledge. Question knowledge. And I also think question the context of the research question. There's always a lot of things that if you read them and it's out of context, it will always go many different ways. For me, I always teach my students, question the context. What is your research question, and what is the context of, what are you researching? I often like journals and research papers that will give you a study context and a study population context. So we're not just zooming into colored women in the Cape Flats, So if you are going to do that, then give us a context. How did you get to that particular study population, and what are you telling us to do in return now that we know about colored women's risk factors in the Cape Flats? Be an interrogative reader. Don't be passive, and always question the context of the research question. Ask yourself, how does this information, for example, like Dr. Peters in table 1, help me answer the research question? What was the aim of this research? And what is this race information adding to that answer? Or is it also just superfluous information that's just added on to make the research paper look fancier with graphs? But, now what? And then I think if we have more interrogative readers who also have the agency to write to journals to say, actually, listen, I don't understand how this got through your reviewers. How is this adding to my knowledge as a reader? If you're going to pay for a journal and you're going to take the time after a long day and you read it, and so question the journals, because I also think there's an agency to health professionals as the audience to whom this evidence-based practice must be a solution for. You must also have the agency to question if there's something that's unclear, if there's something that you just like, I just don't get how we now must function now that we know the difference between white and black people and their risk for for diabetes. What is this saying to me? Because that will, like what Prof was saying, as soon as you call it out, people will be less comfortable just putting tables of race on their research papers and just get to the point. What was your intervention? Was it successful? Was it not? Does it help us? Does it not? Yeah.
I really enjoyed how you brought together both analyzing why it's like, why they included race, and contextualizing the title. And I love, or the research question. And the one thing that I found really interesting when you brought in which journal is it, analyze the journal, it brought up something that I had heard, Prof, you did a previous talk for SurgSoc around around more global surgery based. And you also were speaking a little bit about research and power dynamics. And one of the things you brought in was is the idea of the foreign gaze, and also the impact of the journal that you publish in. It was a really interesting concept to me. I don't know if you just want to speak about it yourself or rather than me.
No, I mean, go ahead. I'll listen.
It was so interesting to me. I just wrote down a few notes while listening to it. Was something to analyze is the foreign gaze. Who's writing? Who's the research being done for? Is the audience not local? If we're not doing the research locally, we're negating local experts. That was just on sort of the foreign gaze idea, which I loved. And then the journal was, for me, which I'd never thought about, was where you publish has an impact on your audience. Publishing in local journals in South Africa maybe does not always have the same impact as an international journal. So if you think of one of the important international journals, New England Medicine Journal, and you'd said for those in America, which is like a huge area where a lot of research comes out of, for them, their local journal is the New England Medicine Journal. That's a local journal for them, but for us, our local journal doesn't have the same impact as the New England Journal of Medicine. So we're trying to publish in their journals as opposed to ours because we don't have the same impact. So I love the idea of analyzing the journal that you're reading.
That was really impactful, Kels. I've never actually heard of the foreign gaze, but I can totally hear the rationale behind what you're saying and how people chase a certain journal, which is local in some contexts, international in other contexts, and how that kind of bleeds into where the knowledge goes to, who it has been done on. But what I especially appreciated was when Vera touched on not being a passive receiver of knowledge, because it feels like, in med schools, like you go to your lectures, you try and like sponge, like retain everything, and then go home and retain everything, and just to kind of lapse out of that and start interrogating what you're reading. That I think is such an important skill in this era, and especially with the kind of conversation we're having. But just to wrap us up, we've chatted about so much. We went from barriers to accessing healthcare, barriers in accessing surgical care. We talked about perioperative care. We discussed South Africa's history. We even took on discrimination against patients, discrimination against healthcare professionals. And I really like the part hierarchy. I think you're talking about how you have a choice between reinforcing that hierarchy or giving yourself the chance to like step back and examine the system that you're a greater part of. Kelsey, do you want to add to anything I've just said?
I think you've done an excellent job. I really enjoyed the fact that we unpacked ideas of unconscious bias and covert racism, and I think that's something that's incredibly important to discuss, and it's not nearly discussed enough in our undergraduate career. And then we're sort of thrown into a healthcare system where then, you know, the onus is on us to deal with it every day. But and I think that that's something that we all need to focus on, is dealing with it every single day in our practice. But I also think sometimes it's okay to ask, look, I don't know how to deal with that. And I think conversations like this maybe start that, how do I deal with it for those that maybe don't know enough on the topic.
You know what I'm thinking, Kels? I'm thinking if I were to be an award round in fourth year and I had to say I don't know how, it just feels so contradictory to what you're expected to do in med school. Like, you're supposed to know everything. And I think as a medical student, like, that conditioning goes so far as to not allowing yourself to say, I don't know what this is. I know this is a system. I know this is a bias, but I actually don't know how to approach it. And it's actually very important sometimes to know what you don't know. You can't kind of waft by saying that you know everything.
Sure. Do any of our speakers want to say anything in a wrap up before we just give our final parting words?
Just really to say thank you very much for putting this together and for thinking about it and for starting the conversation, and also for, you know, giving me some great ideas about what we can do in terms of teaching and making these kinds of conversations more formal in the way that we work. So thank you.
Anything else?
Just in closing, just to say that, look, our curriculum in medicine as well as health sciences in general is very dynamic. And there are always opportunities to change the way things are taught. I've seen that since we did PBL 10 years ago or more. But I think the things that you would want to take from your curriculum when you deal with power and privilege are to always look for the truth. What is the truth? What is being measured? What is a confounder? What is cause and effect? And always be rational in your approach with colleagues, with patients. And then the third thing, which I think we all are still taught, is to be empathic. And so to literally be able to put yourself in someone else's shoes and know that you would most likely make the same decisions they are making if you were of the same socioeconomic status, if you spoke that language. And to actually be able to have that charity to assume that people are being rational in their behavior, even though they live in a completely different world to you. And that's empathy.
I think something that's really important from taking all of this together for those that are going to be listening to this podcast is that in discussing these issues, we realize that it's far bigger than a single podcast. And we acknowledge that, and we know that this is the beginning of a conversation. So I just feel overwhelmed with like so much to learn and grow, and I hope that those listening feel the same way. Asande, on to you.
And just to close on that note, and how we can't always do the entire conversation in 1 or 2 podcasts, it's just important to try, as Prof. Cairncross was saying, try to see where the problems are, try to see what you can do, and try and do your little part in tackling that unconscious bias. I love the way she said it, that feeling in your stomach, you need to listen to it and actually go and do what you think is right. And I think one of the important things as a medical student that I'm taking away from this conversation is just to be introspective and reflective, and to use that nuance. Dr. Peters was touching on being empathic, and it has been so amazing to just sit back and listen to all of you. I've just been like mind blown.
No, same. On my wall is going to be challenge, surface, and change. And I think that's something incredibly important to take from this. Thank you so much for having us. And yeah, stay tuned for the next podcast in the series.